Okay. Well, welcome everybody. Welcome to our Embracing the Change Talking Menopause webinar. We have a very special guest joining us today, Dr. Elaine Wheatchin from UC Davis Health. My name is Connie, and I'm the program coordinator for staff and faculty health and well-being. We're so excited to have our special guest and go through our some of the common themes and questions that are representative of, some of the most common concerns surrounding menopause. So oh, let me give you a little bio on Dr. Wheatchin. So Dr. Wheatchin is a generalist obstetrician and gynecologist who has been on faculty at UC Davis since 2001. She has experience in epidemiological research related to reproductive hormones, aging, and the gynecological health of midlife and older women. Dr. Wheatchin is principal investigator of the study of women's health across the nation, SWAN, which has followed a diverse cohort of women for almost 30 years across the menopausal transition into old age to characterize the physiological and psychosocial changes that occur during this transition. And so I'll turn it over to Dr. Wheatchin, who wants to speak a little bit about the SWAN study.
Good afternoon, everybody. I'm very happy to be here. So I wanted to start out by talking a little bit about SWAN, just because I think it's an important study and one that's relevant to a lot of the questions we're going to be talking about. SWAN is a study that started in 1995, and we took a group of women who were in their 40s and followed them across the menopausal transition. We are currently continuing to follow a lot of these women, more than half of them, into their older years. And so it's a really unique opportunity for us to see how the menopausal transition and other factors relate to the aging process. The other thing about SWAN is part of its goal was to start to try to tease out, epidemiologically at least, the differences between what women's experiences are related to the hormonal changes of menopause, and how that relates to aging, and how that relates to other factors that occur as we kind of transition from midlife into older age, including the onset of new medical conditions, as well as just social changes that occur in people's lives. So that was one of the goals of SWAN, was to be able to tease some of this information out. One of the things that I just wanted to highlight is that SWAN recently came out with a number of fact sheets, which Stacy's going to give you access to. These fact sheets just basically go over some different areas of research that SWAN has investigated, for example, cognition and bone changes. They represent a lot of the major findings from SWAN, but also incorporate some of the other epidemiologic studies that have looked at menopause. Okay, so I think the one other thing that I just wanted to say is that we as menopause researchers are grateful that there is a lot more press and interest in menopause that has been coming up, especially since the publication of that New York Times article. But we also are a little bit concerned that people are maybe having a negative view of menopause, and that it's a transition. It is a condition. It is not a medical condition. And so what I often tell my patients is that menopause is a consequence of aging, not a cause of aging. And I think it's really important that we think about what we know, which is actually quite a lot, but also look forward to the things that we still need to understand. So I fully acknowledge that a lot of the information that we have is not as complete as it could be, but just like with any medical specialty, we do the best we can with the information we have. Okay.
Thank you.
Yeah. So shall we move on to our
Yeah, we'll move on. So these are the topics that we'll be discussing today. So diagnosing menopause, symptoms of menopause and aging, treatments such as hormone therapy, and we'll have a little bit of time at the end reserved for Dr. Fresherman, who will speak a little bit more about the Menopause support group. Just a reminder, we did collect all of these questions and comments from our part one of Embracing the Change series. Dr. Weichin was so kind to look through all of them and selected a few common questions and themes that were representative of your concerns and questions. So we'll get to the questions. Okay.
Yeah, there's a lot of things we can discuss about menopause, but the first series of questions were about diagnosing menopause, and so I thought this was worth talking about. So there were a number of questions about, for example, what do you do if you've had a hysterectomy? How do you tell if you're in menopause after that? What about hormonal birth control methods like the IUD? That suppresses periods, or birth control pills that will give you a period even if you're past menopause because of the hormonal aspects of those medications. So I want to start by just basically talking about how we diagnose menopause. It's actually what we call a clinical diagnosis, meaning that we gather information from what our patients tell us and then make the diagnosis based on that. It is not really a diagnosis we use hormones to diagnose. Um, so the perimenopause is a time where typically women's periods start to space out, and that typically occurs between the ages of 40 and 50. And then the menopause is defined as not having a period basically for 12 months. So, and then in conjunction with that, we know that menopause is a very individual experience because we have patients who have zero symptoms at all, and sail through without any bother. And then we have patients who have very bothersome symptoms that really are sometimes hard to manage, and need help from providers that can help with that. So if somebody has no symptoms, in some respects, the diagnosis of menopause becomes a little less important because we're not having to specifically address those symptoms. But for women who are bothered, then, and also for the fact of trying to figure out whether people can get pregnant or not, this becomes more important. So just getting back to that, um, uh, it's a clinical diagnosis. Measuring hormones to try to determine whether somebody's in menopause is a challenge because if, for example, you skipped a few periods around the age of 50 and we were to get the measures of hormones that we relate to menopause, which is the FSH and an estradiol level, for example, this would only tell us about that moment in time because it doesn't predict that you won't have a period again, because perimenopause people can skip periods for months at a time and then get another one. And so that's one reason we don't use hormones as a measure of where you are to diagnose menopause. For women who've had a hysterectomy, if you're one of those people that sail through without symptoms, we'll never know exactly the age that you would have passed through menopause. But for women who do have symptoms, then we just manage symptoms of menopause when they come up around the average age of menopause, which is around the age of 50. If you have an IUD that's suppressing your periods, then it becomes a conversation, because on the one hand, the IUD can be very useful for somebody who has symptoms because we can use it as part of the hormone therapy regimen. The hormone in in the IUD is a progestin that helps protect the lining of the uterus from the estrogen that we usually give to treat symptoms. And so leaving the IUD in and using it as part of that hormone therapy can be a very useful thing. IUDs generally give off enough hormone to protect the lining, we think, for about 8 years. But But if somebody doesn't want it in, then it becomes, again, a personal conversation about when a woman might want to take the risk to see if they're truly in menopause or not, and have backup plans for birth control. And that's the same way with birth control pills. If you're on birth control pills around the time of menopause, we have to have a conversation about whether you want to go off to determine if you're having symptoms or if you're going to continue to have periods. So it's not clean, it's a little messy, and it's very individualized. The other question may be related to do these methods of birth control or having a hysterectomy, or for that matter, this other question about having children, having many children or no children, affect menopause? And the answer is, from a clinical perspective, not much. If hysterectomy has any impact, it's probably a matter of maybe a month's difference in when you would otherwise go through menopause, for example. And so generally these things don't actually impact the age you're programmed to go through menopause. So hopefully that makes some sense.
Great, thank you. Okay, so we're moving on to symptoms talk.
So this is actually, I think, the part of menopause that I want to spend the most time on, because I think this is the part that can be very confusing and is not fully sorted out, but I think we do have some good information that I can pass along. So the first question was related to what symptoms are scientifically linked to menopause versus those that just might be experienced around the same time. And this gets back to that question or that comment that I say, menopause is a consequence of aging and not a cause of aging. So I like to think about, because menopause is basically a hormonal change, but it's also advancing age change. And the one thing that Swan's been able to do is help us tease some of those things out. So there are two symptoms that are unequivocally related to menopause and the lower estrogen levels that are associated with traversing menopause into postmenopause. And those are hot flushes and vaginal dryness. There's no controversy about those. There's no qualifications really about those. In fact, when somebody has hot flushes around the time of menopause, we don't check to see if there's any other medical conditions that might be related, because it's such a hallmark. And these are two symptoms that we know for most women improve with estrogen treatment. So if you're having hot flushes, there is very, very good effect for most women of taking estrogen to treat these hot flushes. Same with vaginal dryness. Vaginal estrogen is also very effective, or sometimes the estrogen you take by mouth or through the skin can also treat that symptom. So these are the two hallmarks that are not only specifically related to menopause, but also treatable and clearly treatable with estrogen therapy. So the next kind of bucket or category would be the symptoms that are kind of purely aging related. And an example of that, that actually this was one of my big areas of research in Swan in the early years that I was with them, was I looked to see if urinary incontinence was actually a symptom of menopause or a symptom of aging. And the body of my work basically showed that urinary incontinence is a symptom of aging. People tend to notice it around the time of menopause. And so if you look online, it will be listed as a menopausal symptom, but it's not a hormonally mediated symptom of menopause, and therefore not treatable with hormones. In fact, the bulk of the data on urinary incontinence is that most of the time it's going to make it worse rather than better, actually, by a small amount, but that's what the data suggests. So that's an example of the bucket of not a menopausal symptom from the standpoint of the hormones and not treatable by hormone therapy. So then there are other things that happen to us around the time of menopause that are related to both aging, and hormones, but exactly how that works and whether they're actually treatable with hormones is a lot more questionable. So an example of this is cognitive changes. Cognitive changes happen as we get older. They happen to men. They happen to all people. They do tend to be worse for women around the perimenopause, and that's where the hormonal changes may be contributing. And but in general, a lot of those cognitive changes are not going to be treatable with hormone therapy. So here's an example of a symptom that has both aging and hormonal mediation, but the evidence doesn't support that the cognitive changes can be treated primarily with hormone therapy. Now, there's caveats to this. It's complicated, right? So, for example, if you have hot flushes and those hot flushes are disturbing your life and interfering with your sleep, your disturbed sleep is going to affect your cognition. So women who have hot flushes or night sweats that are affecting their sleep are going to have improvements in their cognition from taking hormone therapy because you're primarily treating the underlying cause of a lot of those cognitive changes. So this is also true of fatigue, for example. This can be true of weight changes because sometimes if we're not sleeping well, we're under more stress and we're not exercising. So there are ways in which hormone therapy can affect some of these other symptoms. It's just not necessarily a direct thing. Okay. I hope that that helps to answer that question. I won't go through all the symptoms, but I think thinking about those buckets of symptoms, some that are treatable by hormones, some that are related to hormones, but not primarily treatable, but maybe downstream are treatable, and then those that are just related to aging. So the next question was, how do I talk to my doctor? So there were a lot of these kinds of questions, and I think this is reflective of the fact that unfortunately there aren't as many physicians that are as comfortable managing menopause and menopausal symptoms and symptoms, sorting out that difference between aging. So I think the first thing that I would say is that if you're just having some specific, for example, if you're having just cognitive changes or you're just having weight gain, hormone therapy would not be indicated for those things. And so I think it's partly going to be what you're expecting and what you're asking from your physician. So it does get a little bit complicated because there are indications for hormone therapy with downstream benefits, but then also there are situations where we wouldn't necessarily recommend it for someone. So I would say that, first of all, being clear about what the symptoms you're wanting to manage are, being clear about what the guidelines could be or are for treating hot flushes, for example. And then making sure that your expectations are in aligned with that physician. If that physician you do not feel is listening to you or addressing your symptoms, there may be other people that could do that. I do think that we need more education for physicians, so I'm on board with that whole concern that everybody has, and I'm hoping that some of the media around menopause will encourage that. So So this question, again, was also a very common theme, and that is that there's a lot of things going on in midlife and as we get older that could very easily represent changes that are associated with menopause, but sorting out what is and what isn't is also critical. And I would just say that this actually represents one of the things that I also like to tell my patients when somebody comes in with problems with sleep, but, for example, but are not having any hot flush symptoms. Um, Prescribing hormone therapy for that person because of the sleep disturbances, thinking that maybe hormone therapy would help, would not be the right thing to do for that individual. And the reason is that there are a lot of conditions that can occur around this midlife time that are not at all related to menopause. And if we misconstrue those symptoms to be menopausal, we might miss important diagnoses. So for example, I've diagnosed people with sleep apnea, sent them off to sleep for sleep evaluations. And in that situation, actually treating the true cause of that problem rather than assuming it's related to menopause is very important. Um, Sometimes it's hard to tease out what is medical and what is menopause related. But in general, we want to go through the process of making sure we're evaluating for all those symptoms that are not specifically related to menopause, hot flushes and vaginal dryness. We want to make sure we rule out other causes of those symptoms before we kind of go back to that being a menopausal symptom.
Right.
In that regard, it may be that there is not one treatment for all these situations, that there has to be individualized treatment, one for depression, for example, one for the hot flushes, and that, yeah.
Great. Elaine, if I may insert a question here. Somebody asked, how can they set themselves up for success? Is there a way that they can experience less symptoms, if possible, prior to reaching menopause?
Uh, Good question. So there is no known way that one can prevent hot flushes, for example. That seems to be a pre-programmed thing for individuals as far as we can tell. There is not any particular way that we know how to prevent vaginal dryness specifically. That also seems to be something that may be individual. There are ways to prevent um, things that happen across the menopausal transition. So, for example, we know that bone density goes down, and that with that, often bone strength goes down. So, for people who are not going to be using hormone therapy, for example, making sure that you stay physically active, doing weight-bearing exercises, making sure that you are taking sufficient vitamin D and calcium, not necessarily supplemental, but just making sure you're getting enough of that, are ways to prevent the bone loss related to menopause. So, um, and same with cognitive changes. I don't think that there's any specific unique knowledge of saying I can do X, Y, and Z before menopause in order to make sure I have less cognitive changes.
Great. And one more, just I think this might be related to symptoms as well. Would somebody who's going through this transition, are they also more prone to getting urinary tract infections, if you happen to know?
So there are changes in the vagina that do make people more prone to urinary tract infections. So the normal vagina is filled with a bacteria called lactobacillus. And when estrogen levels are lower, there's less of that, not in everybody, but in a substantial number of postmenopausal women. And when there's lower numbers of lactobacillus, there's less of the soldiers that fight against bacteria that cause urinary tract infections. So we think that that's one mechanism that actually using vaginal estrogen can reduce recurrent urinary tract infections if that is the relationship to the reason for people are having recurrent urinary tract infections.
Perfect. And then I'll just take one more. Sorry, we're starting to get a lot of comments and questions. Do you know anything about migraines and if that's linked to menopause?
Also a good question, and I will say this is one of those other that's individualized. So there's a subset of people who have migraines that absolutely stop at menopause, and so that's one of the very positive things for those people of going through menopause is that clearly their migraines were hormonally mediated, and when a lot of those hormones are lower, it's better for them. But there is also a subset of people who go the opposite direction. And their migraines start around the time of menopause. And again, it's a very individual thing. I don't know much more about it than that.
Okay, great. Thank you. Let's move on to our next set of questions, and then we'll see if we can take more from the audience. Okay, so treatments.
Okay, so here's a question about whether hormone therapy is a marketing scheme and whether it's really necessary. You can go ahead and put up the other questions
Sure.
because I think that this is wrapped up into kind of the whole concept of hormone therapy. So yes, menopause is a natural process. There are some people who sail through without symptoms, but certainly hot flushes can be pretty distracting and pretty impactful on people's lives. And so having some form of treatment can be very helpful to people. And the best treatment, the most effective treatment is hormone therapy. Now, you hear me refer to it as hormone therapy, not hormone replacement therapy. And that is because the Menopause Society that has really excellent guidelines, which is the guidelines that I generally follow for managing women who are having symptomatic, who are having hot flushes. We like to use the term hormone therapy rather than replacement because, again, replacing assumes that we're replacing something that should be there rather than just treating symptoms specifically with a form of medication. So I would say no, it's not a marketing scheme. There's an interesting history to hormone therapy that has aspects to that. And it's not worth going into at this point, but it is an interesting history. So hormone therapy is FDA approved for treating hot flushes. And if one has just vaginal dryness and no hot flushes, then vaginal estrogen. I want to talk a little bit about the pros and cons of hormone therapy, and then a little bit about the different types of hormone therapy. So what are the pros of hormone therapy? Well, certainly just what I said, it's the most effective treatment for some of the most bothersome symptoms and potentially has those downstream effects if you're having hot flushes and night sweats that are interrupting your sleep. Hormone therapy also does protect the bone. So the bone density in women who take hormone therapy is higher than women who don't and protects against fractures. There are a lot of other kind of positive side effects of hormone therapy. There does seem to be a decreased risk of diabetes, although I would add that the decreased risk is not a reason to take hormone therapy because there are plenty of other ways to prevent diabetes that are more effective. But that is a side benefit. Those are the main benefits of being on hormone therapy that are kind of promoted. What are the cons? Well, there are risks to being on hormone therapy. And I'm sure everybody knows about the WHI that came out and kind of slammed hormone therapy. I think that we've learned a lot from that study. And I think that there are ways in which that study has been extremely informative. But basically, the current practice for hormone therapy is if you're having bothersome hot flushes, and don't have any clear contraindications for being on hormone therapy. For example, if you've never had a heart attack, stroke, or have had breast cancer or something like that, that being on hormone therapy is relatively safe for women in their 50s and can be safe to continue for a lot of women into their 60s, but in general would not be something that people should start um, many years after menopause, because the risks seem to increase if you have, for women in their 60s to start hormone therapy is considered kind of the riskiest thing to do. Are the risks huge? No. But do they exist? Yes. The reason that it increases the risk of heart attack and stroke is that estrogen is something that causes an increase in the clotability of blood. So as you get older, your blood vessels automatically narrow with the plaque that gets placed. That is for most people in life, that's what happens. And when you are taking estrogen makes it more likely for you to form that clot. This is one of the prevailing theories about why hormone therapy is more risky. And so you're more likely to form that clot, therefore more likely to have the heart attack or stroke. We think that there are safer ways to give estrogen. It's not risk-free, but giving estrogen through the patch, through the skin, is probably safer and has a lower risk of those clots. And for women who don't need to take that progestin component, we think that hormone therapy is a bit safer. But taking hormone therapy, if you have a uterus without the progestin, it's not safer because estrogen increases your risk of cancer of the lining of the uterus. So those are the pros and cons of hormone therapy. See, what's the next question? So this is a really good question that there were a number of people asked, is what's the difference between biosimilar, bioidentical hormones and pharmaceutical versions? So there are multiple different formulations within the pharmaceutical industry for hormone therapy, and then there's compounding hormones that is kind of more of what the bioidentical people associate with bioidentical. So within the pharmaceutical industry, we have pills, patches, and then we also have different versions of estrogen and progestin. So for example, Premarin, which was the most popular estrogen for people to be taking, is an estrogen that's manufactured by synthesizing urine from pregnant mares. That's how it got its name, Premarin, pregnant mare's urine. And that particular, that's not a bioidentical or a biosimilar hormone because it's horse hormone. But the pharmaceutical industry also makes pure estradiol. And you can take that as an oral formulation, you can take it as a patch formulation, and you can also take it as like a topical spray or a vaginal ring. And so a lot of times when my patients come to me, they're looking for bioidentical, but what they're really looking for is something that's a natural estradiol, and there's plenty of that within the pharmaceutical industry. Similarly for progestins are synthetic versions of progesterone, which is the natural hormone that the body produces. And there are different formulations of progestins, which are, again, not bioidentical, versus the progesterone. So there has unfortunately have been very few studies looking at estradiol, which is the more bioidentical estrogen, and progesterone, which is the more bioidentical. But we in the menopause community do believe that those are safer. They're not without risk, but we do believe, especially given through the route of by patch, for example, is safer. Um, the bioidentical compounded hormones is a little bit more problematic because it's unregulated. And so that means that whatever you're getting in your compounded hormones may not be the same from each time you get it. And it also may not be similar between different pharmacies. And then also, a lot of times it's promoted as being completely safe compared to any pharmaceutical, which we also don't believe is true because the compounded hormones are basically the same as what you would otherwise get from a pharmacy just put into compounds. So I hope that answers that question. The last one is what can one do to manage symptoms if one has breast cancer or another reason that they cannot take hormone therapy? So this again depends on the symptoms. So for example, if you're having hot flashes, there are some medications, unfortunately not as effective, but can be helpful to a number of women. There are low dose antidepressants. There is a low dose gabapentin, which is a medication that's often used for pain, but also has been shown to be helpful with hot flushes. And then there's a new medication on the market that is a non-hormonal medication specifically for hot flushes. Just like with any new medication, however, it's not easily covered by insurance and is expensive. And I can't remember the name off the top of my head because it is the compound name is it starts with an F anyway. So it's hard to get at this point. There's also kind of behavioral things that people can do. So for example, a lot of people's hot flushes tend to be triggered by different things. And so figuring out what those triggers are and avoiding them. Wearing layered clothing is one thing that everybody talks about. Some people benefit from complementary treatments such as acupuncture, that sort of thing. So
Yeah, and just related to the last question, somebody also asked if they're at risk for high risk for breast cancer. What would you recommend?
So it depends on the risk. So usually women, women have risk for breast cancer because of genetic reasons. In other words, they're BRCA1, have BRCA1 or BRCA2. So those women, hormone therapy doesn't seem to particularly affect those risks significantly. Let me qualify. For BRCA1, there doesn't seem to be that much of a difference. For BRCA2, there seems to be some association. But for people who don't have known mutations, but a family history, that's not a contraindication for using hormone therapy.
Thank you. And I wanted to, I think, back up just a bit to the diagnosing part. We had quite a few questions about measuring your hormone levels and if that would be a good indication for somebody who's about to enter the menopause transition.
Yeah, so I think that I probably didn't, I glossed over that a little bit. So the reason that it's hard, so when we're in before menopause, having menstrual cycles, if we were to measure your estradiol, which is one of the hormones that we measure, it's an estrogen, and FSH, which is a measure of a hormone that's produced by the brain, we would find that those vary from day to day. So every single day, those levels are different. Um, and so there are times that we might capture a day where it would even look like you're in menopause if we were just to capture that one day. As you are traversing the perimenopause into menopause, where your periods stop, those hormone levels are rising and falling when you have a period. Or sometimes what happens is that as your ovaries are working, you may not release an egg, and some of those levels might go super high compared to when you're having regular periods. And so um, the measuring hormones is capturing a moment in time for something that can change not only from day to day, but can change from month to month. And so for example, if you do have a level that has a high FSH and a low estradiol, which would be associated with being in menopause, that can stay that way for 3 months when you're in perimenopause and then suddenly change because your ovary produces another egg, you have another period, and your hormones are going to be going back up and down again in that daily change. So that's the reason that we don't find much use in measuring hormones, because they don't really tell us enough information to really do anything about it. And so what I will say is that it's the $1 million question and also the $1 million uh, um, reward for somebody who's able to find a test that not only tells us for certain that somebody is never going to have a period again and thus are in menopause, or to be able to predict, oh, you're going to go through menopause in the next 3 months, 6 months, 2 years. It's just not possible. That doesn't exist yet.
Thank you. I think you answered a lot of those questions today. Thanks. And I believe you mentioned this, but how long can somebody take hormone therapy? I believe you mentioned higher risk when somebody reaches their 60s, but please feel free to correct me. And do you know if hot flashes will return when hormone therapy is discontinued?
Both very good questions. So first, I'm going to answer the second one first, and that's to say, it seems that every person is pre-programmed with how long they're going to have hot flushes. And so if you um, if you are on hormone therapy and then decide to stop at age 58, you're going to either be somebody who's going to go on to continue to have hot flushes, or your hot flushes will have completed, been over, done. So no, just going off hormone therapy doesn't automatically mean you're going to either kind of go through another menopause and start having hot flushes again. It just depends on who you are as an individual. So the second part of the question is, our ideal situation is to start people on hormone therapy if they're having hot flush or, bothersome hot flush and night sweat symptoms. Um, and then maybe towards say if they're in their early 50s, and then maybe towards the mid to late 50s, just to start talking about whether you want to try to go off. Because if your symptoms are not there anymore, if your hot flush symptoms have come and gone, then there may not be a reason to need to stay on the hormone therapy. And so usually around the age of 60, we at least do a trial of trying to come off hormone therapy. But there is a subset of women that go on to have terrible, bothersome hot flushes into their 60s. And so as long as there's no other significant risk factors that are going to make hormone therapy kind of more threatening than those hot flushes, like the diagnosis of breast cancer or a heart attack or stroke, then continuing on is a reasonable thing. What I usually do is I just see people on a roughly annual basis to kind of rehab that conversation, to see what medical things have changed, to see whether it's the right thing to do.
Great. Thank you. And I wanted to just insert one more question here about, I think, more navigating medical care. Somebody is just they're experiencing hot flashes, night sweats, weight gain, hormonal acne. They're feeling depressed, that they just can't see an end to feeling this way, but their OB-GYN continues to tell them that they can't use hormone therapy. Is there something that you would suggest?
So, I mean, I guess the important things is making sure that there's no absolute contraindications to hormone therapy. For example, having had a heart attack, stroke, or breast cancer. Those are kind of the biggest ones. Um, if none of that's true, then it's possible that the OBGYN is maybe not as up to date with the North American Society guidelines on hormone therapy, and it might be worthwhile to seek out somebody who is more comfortable with prescribing in this particular situation. It's hard for me to know what the cause of that "I won't prescribe for you" is. Sometimes it's because of good medical reasons, but sometimes it is people just are not comfortable doing it because they haven't had the training or are not up to date with the guidelines.
Perfect. Well, thank you so much, Dr. Weichin, for joining us today. I wanted to take a few moments here and I'll give the mic over to Dr. Fejerman before we give all of our speakers today our thank yous. So let me spotlight you, Dr. Fejerman, and if you'd like to speak a little bit more about this support group.
Yes, thank you so much. Thank you, Dr. Wajan. We were very much needing this. And I already received emails saying how amazing it was to just listen to you and learn a little bit more. We, just to let everyone know, we created with a friend of mine at UC Davis, a group called Menopause a while ago, a few months ago, and we meet every month. It's the first Friday of the month at 4 p.m. And we meet virtually, and it's a support group. So there's no expert in the room. We meet, we go into breakout groups just to be able to, so everyone can share. And we keep changing the structure, but now we're gonna have themes in the breakout room, so you can choose what you want to talk about that day. We'll also have like a room for free venting and sharing. And it's really about supporting each other, sharing exercise, nutrition tips, things that help us live better. Our frustrations with the physicians who don't listen to us, so we listen to each other. We try to clarify some questions just together. Some people already been asking and know, so we give answers to each other. And everyone is welcome to come. You don't have to come every time. We have people who show up 1 month and not the other month, depending on how they are feeling. But it's a really nice environment, very supportive. And everyone is welcome, including people who are not from UC Davis. So we've been asked, and we now have people from other places that learn about the group. So that's about it. If you want to be added to the monthly invitations, just shoot me an email and I can add you.
Thank you so much. Well, I'd like to invite everybody to give your thanks to Dr. Weichin for spending time with us today, answering all of these common questions and addressing the themes surrounding menopause. We are at time at 1 o'clock. So just a reminder, check the chat for all of those wonderful resourceful links, especially those SWAN fact sheets that Dr. Weichin mentioned. And we'll have this webinar recorded and posted on our Healthy UC Davis YouTube channel in the near future. And plus, please consider giving us your feedback and kind of suggestions for future topics. We are not going to end the conversation here, so we look forward to connecting with you again in the future. So thank you so much, Dr. Weichin, for being our speaker today, answering these questions, and taking the questions from the audience live. So thank you so much.
Happy to be here. Thanks so much.